Welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. Thank you for joining us today for 2023 flu season. Why timely testing and treatment are key to staying healthy. A non-CME program of our Dr. John G. Bartlett Memorial Education Series. And special thanks to our webinar sponsor, Genentech. Before I turn the program over to our host and moderator, a few housekeeping matters. This webinar is being recorded and will be available on demand if you can't stay for the entire presentation. A link will be emailed to all registrants within 3 business days, or you can access it and share it via our website and the IDSA YouTube channel. You'll notice that your microphones are muted, but please use the Q&A feature to ask questions during the event. There will be a dedicated Q&A session at the end. If we can't get to all the questions, we will do our best to address them in a follow-up email. Now, I'd like to introduce our host and moderator for today, Dr. Mary Rose Lagiovilla. Dr. Lagiovilla holds the positions of Infectious Diseases Division Chief, Antimicrobial Stewardship Program Director, and Associate Program Director for the Internal Medicine Residency Program at Rochester General Hospital in Rochester, New York. Dr. Lagiovilla, over to you.
Thank you, Diane, and good afternoon, everyone. I'm Dr. Lagiovilla, and being on the cusp of the upcoming 2023-2024 respiratory viral season, this webinar is well timed. Our objectives today are to highlight the clinical presentation and burden of influenza infection, to identify patient populations at highest risk for influenza complications, and recognize ethnic and racial disparities in influenza outcomes and gaps in rates of vaccination. We will also review the different types, advantages, and disadvantages of influenza testing platforms, discuss testing guidance for clinicians when influenza and COVID-19 are co-circulating, and examine protocols for expanding testing and treatment algorithms across the healthcare spectrum. Now it is my pleasure to introduce our first speaker, Dr. Dial Hewlett. Dr. Hewlett is currently Medical Director of the Division of Disease Control, Chief of Tuberculosis Services at the Westchester Department of Health. Dr. Hewlett received his MD from the University of Wisconsin in Madison and is board certified in both internal medicine and infectious diseases. He completed an internal medicine internship and residency at Harlem Hospital Center, Columbia University College of Physicians and Surgeons in New York City, where he was also selected to serve an additional year as chief medical resident at Harlem Hospital. Following residency training, Dr. Hewlett went on to complete a 2-year clinical and research fellowship in infectious diseases at Montefiore and Albert Einstein affiliated hospitals in the Bronx. Dr. Hewlett served as the Chief of Infectious Diseases at Lincoln Medical and Mental Health Center in the Bronx, New York, and Associate Professor of Clinical Medicine for 9 years prior to joining the pharmaceutical industry in 1996. During that time, and until 2014, he served as an infectious diseases consultant at Lawrence Hospital in Bronxville, New York. He's a fellow of the American College of Physicians, as well as the IDSA, and the New York Academy of Medicine. He currently serves as a consultant in infectious diseases and chair of infection control at Calvary Hospital in the Bronx, New York. He is also an adjunct associate professor of immunology and microbiology at New York Medical College in Valhalla, New York. Dr. Hewlett, welcome, and thank you for presenting with us today.
Thank you, Dr. Lagiovilla, and I really appreciate the introduction. And good afternoon or good morning to those of you who are on the West Coast. If we can go to our first slide here, I was reminded by that introduction that the term influenza actually came from the fact that this disease was well recognized as being influenced by the seasons. And seasonal influenza is an acute respiratory illness that's caused by either influenza or influenza B viruses. Influenza occurs in outbreaks and epidemics worldwide, mainly during the winter season. And we don't get epidemics every year, fortunately. And that's because the antigens that make up the virus only change gradually or slightly from year to year, and it's what we call an antigenic drift. But when there are major changes or antigenic shifts, which occur every 8 to 10 years, that's when epidemics are likely to occur. Influenza is usually a self-limited infection and is associated with increased morbidity and mortality in certain high-risk patient groups. Now, what are some of the clinical manifestations of influenza? Well, typically the incubation period is from 1 to 4 days, average about 2 days. The time between onset of illness among household contacts, known as the serial interval, is 3 to 4 days. Now, as far as the signs and symptoms, influenza characteristically begins with an abrupt onset of fever. Usually there's a non-productive cough and there's myalgias. In some cases, the onset is so abrupt that patients can recall the precise time at which their symptoms began. Fever usually ranges from 37.8 to 40 degrees centigrade, or from 100 to 104 degrees Fahrenheit. We go to our next slide, please. As far as general management is concerned, fortunately, most individuals will have a self-limited illness. However, some people are severely impacted. Hospitalization is warranted for patients with significant dehydration or for severely ill patients, especially those with respiratory distress, hypoxemia, impaired cardiopulmonary function, or those with an altered mental status. In the absence of these findings, admission for observation may be warranted for patients with increased risk for complications. It is important for us to make sure that the patients remain hydrated. Acetaminophen or nonsteroidal anti-inflammatory drugs may be used for the management of fever, headache, and myalgias. We go to the next slide, please. Now, what is the burden of disease? Influenza is something that has always been with us, and it is something that is preventable. And so it's important for us to put into perspective how this impacts our society here. And the fact that this is a preventable illness places a responsibility or a burden on those of us who are healthcare practitioners to educate our patients and to make sure that they avail themselves to the preventive measures, which include, of course, most importantly, vaccination. But you will hear later on during this program about treatment options as well for those who still develop illness. And so this slide actually illustrates an estimated range of annual burden of influenza in the United States between 2010 and 2020. You can see that illness occurred in about anywhere ranging from 9 million to 41 million individuals. This is an estimate. Hospitalizations range from 140,000 to 710,000. And deaths range from 12,000 to 52,000. So 52,000 deaths is really a large number of individuals that are dying from something that should be a preventable disease. We go to the next slide, please. Now, there are certain groups who are well recognized as having a higher risk for the complications of influenza. These include our children under the age of 5 years, but especially those who are under 2 years of age. It is very important for us to make sure that our young children receive the vaccination. And in fact, we should always keep in mind that the vaccination is indicated for all children 6 months of age and older. We are also more likely to see complications in adults who are 65 years of age and older. We are also more likely to see complications occur in our pregnant mothers, those who are up to 2 weeks postpartum. It's very important for us to keep this in mind because during one of the more recent outbreaks with the H1N1 influenza back in 2009, pregnant women were among those who were often impacted with fatal outcomes due to influenza. So it's important to encourage our OBGYN colleagues to vaccinate their pregnant women, and also for us to encourage those in our families and those who are our friends and neighbors to be vaccinated. Also, we're more likely to see complications in residents of nursing homes and long-term care facilities, and also in individuals who are non-Hispanic Black individuals, Hispanic or Latino persons, and also American Indian or indigenous individuals and Alaska Native persons. Next slide, please. And there are groups that are at a higher risk for influenza complications based upon underlying medical conditions. And there's a whole list here, as you see, including asthma, neurologic disorders, chronic lung disease, heart disease, blood disorders, including sickle cell disease, endocrine disorders, most importantly, diabetes, chronic kidney disease, liver disorders, metabolic disorders, those with a weakened immune system, including those with HIV, those with cancer, or those who are on immunosuppressive medications, such as individuals that are receiving medications for inflammatory disorders, are particularly at risk. And finally, but importantly, individuals with class 3 obesity. This was really brought out and brought to our attention during the pandemic or the epidemic of H1N1 back in 2009. Next slide, please. Now, the influenza outcomes. Let's look at a few numbers here. Let's look at those related to pregnancy status and those related to age. During the 2009 H1N1 pandemic, pregnant individuals accounted for 5% of all influenza deaths. And it's important for us to keep this in mind because we are talking about young women who are dying from a disease that is totally preventable. Pregnant and recently postpartum patients within 2 weeks after delivery are at a moderate risk for complications. And the estimated, if we look at age, the estimated mean annual associated mortality rates were ranging from 0.1 to 6.4 per 100,000 individuals among those who were less than 65 years of age, but from 2.9 to 44 per 100,000 among those 65 to 74 years. Next slide, please. Now, there are also disparities when we look at racial and ethnic factors here. Black, Hispanic, and American Indian or Alaska Native persons have had a consistently higher rate of severe influenza outcomes, including the need for hospitalization and ICU admissions. And this is based on data between 2009 to 2019. Compared with white individuals, age-adjusted flu hospitalization rates were nearly 2 times higher among Black persons, 1.3 times higher among indigenous individuals, and 1.2 times higher among Hispanic or Latino persons. Influenza-related ICU admission rates were 1.7 times higher among Black persons, 1.4 times higher among American Indian or Native American persons, and 1.1 times higher among Hispanic or Latino persons. Next slide, please. And one of the things that is a take-home point here is that influenza vaccination rates really are important for us to look at, and the vaccinations or influenza shots are essentially the key to preventing influenza. And we see that there are disparities here, and that these disparities in terms of vaccination rates may very well partially explain why there are differences in outcomes of influenza. And if we look at this cohort, which included 278,538 individuals, 82.8% of the white individuals in this cohort were vaccinated, while among Black individuals, only 54.8%. Among Hispanic individuals, 87% of a cohort of 214,307. And this is information from the Centers for Disease Control in 2022. So there is certainly a lot of work for us to do. The next slide, please. Now, importantly, And this is very important here for our pediatric colleagues and those who take care of children and those who have children in their families. Influenza vaccine is indicated for all children 6 months of age and older. Children younger than 5 years, especially those younger than 2, are at higher risk for developing serious flu-related complications. And so this is not something that spares children. And it's important for us to make sure that our children are vaccinated. Next slide, please. So the CDC also encourages influenza vaccine during pregnancy to protect the mother and the baby. And so many people are under the false belief that women who are pregnant should not receive the flu vaccine. And quite the contrary. This is a very important group to be vaccinated. And as best we know, the vaccination does not cause any harm to the unborn infant. Women who received a flu vaccine during pregnancy had lower risk of certain negative birth outcomes, including fetal death, stillbirth, preterm birth, and low birth weight infants. CDC recommends flu vaccination during pregnancy. Flu vaccine coverage among pregnant women in the United States fell. This was during last year, 8 percentage points, and that was occurring during the previous 2 seasons. And preliminary coverage for what was then the 2022 to 2023 season indicated vaccinations were down another 5 percentage points from this time in 2021. And so there's certainly work to do here as well. We want to encourage our pregnant mothers to take the flu vaccine to protect themselves and also to protect the newborn who is at high risk for developing complications if the mother develops influenza. And my next slide, I think that we will close. And I want to thank you for listening to this presentation. And I will turn things back over to Dr. Lagiovilla. Thank you.
Thank you, Dr. Hewlett. As a reminder to the audience, please use the Q&A button to ask questions at any point in the presentation. So next, our next speaker, it is my pleasure to introduce you to Dr. Michael Klepser. He received his Doctor of Pharmacy from the University of Michigan College of Pharmacy in 1992. He completed a pharmacy practice residency at Detroit Receiving Hospital and University Health Center, followed by a fellowship in infectious diseases at Hartford Hospital in Connecticut. Dr. Klepser has been a professor of pharmacy at Ferris State University since 2001. And prior to joining Ferris, he was an associate professor at the University of Iowa College of Pharmacy. His research interests include use of CLIA-waived point-of-care tests in community pharmacies and community-based antimicrobial stewardship. He has published extensively on these topics and has more than 150 peer-reviewed manuscripts to his credit. He is a founder and content advisor for the Community Pharmacy-Based Point-of-Care Testing Certificate Program. He is also the Senior Director for the Collaboration to Harmonize Antimicrobial Registry Measures, also known as CHARM program. Dr. Klepser remains active in several professional organizations, including the Society of Infectious Diseases Pharmacists, the American College of Clinical Pharmacy, and the American Pharmacists Association. So thank you, Dr. Klepser, for presenting with us today.
Thank you, Dr. Lagiovilla. Why don't we go to the next slide? First thing I want to do is, just bring us up to speed kind of where we are in terms of this season's respiratory pathogens. And according to the CDC, this year is expected to bring a moderate COVID wave, which is thought to be has the potential to cause as many hospitalizations as it did last year. And if any of you guys have run into family members and so forth, or coworkers, there's been quite a bit of COVID going around recently, and you can see on the graphs hospitalizations and ER visits both been trending upwards over the last several weeks, and those predominantly have been driven by COVID-19. The CDC also predicts that the influenza season will be around a typical range in severity, and RSV circulation is going to return to its seasonal pattern like it followed last year and kind of pre-pandemic types of patterns. So we go to the next slide. In terms of mortality and death caused by pneumonia, influenza, and COVID-19, obviously the past few years we've seen an excess of deaths caused by respiratory pathogens, owing predominantly to COVID-19. What we've seen over the past year is these levels have started to trend toward normal, but as we've seen an uptick in COVID activity, we're starting to see again an uptick in our deaths related predominantly to COVID-19. Next slide, please. In terms of preparing ourselves in North America for the upcoming respiratory season, it's important that we can kind of look at the Southern Hemisphere to get a little of an idea of what's occurred there and perhaps give us a little insight into what we can expect in this coming season. And what we've seen predominantly, especially in Central and South America, is the predominant strain this season has been an H1N1 strain. And of note, influenza season has typically started relatively early in a number of South and Latin American countries this season. In fact, Mexico also experienced abnormally high influenza activity back in May and June. So if those are any indications, I would expect to see that we maybe have a early influenza season in North America as well. Next slide, please. The other thing I want to throw out there is we talk a lot about influenza, we talk a lot about COVID-19, but there are a lot of other respiratory pathogens out there. And again, looking at what's going on currently, you can see back through the pandemic years, a lot of our respiratory viruses were not a lot of these background viruses like adenovirus, bocavirus, and so forth. But what we're seeing right now, especially in Central and South America, is that there's a lot of diversity in viral pathogens. And I think it's going to be important for us to keep that in mind because we're not just talking influenza season or COVID season or RSV season, but there's a lot of other potential pathogens that we might be encountering as well. Next slide, please. Currently in the United States, our influenza activity is low, which would be expected at this point in time. Unfortunately, if we look down in the southwest part of the United States, especially in New Mexico and Texas and so forth, we're starting to see a little lightening of the states, meaning that there's been an uptick in influenza activity. And knowing what we've seen in Latin and South America this past season, unfortunately, this might continue to grow. And along with that influenza activity, I'm expected that we are going to see a mix of a variety of other pathogens mixed in there as well. Next slide, please. So I want to talk a little bit about testing for respiratory viruses. And I know historically, influenza tests, especially CLIA wave tests, had kind of gotten a bad rap because some of those really did not perform well. But what we've seen through the pandemic and continuing on is really an improvement in the technology that is being used to develop these tests. And why would we want to even consider testing? Well, first, it's going to be important for us to determine what is and what is not causing infections. Respiratory viruses have a lot of overlapping symptomatology, and we're not able to differentiate which pathogens causing symptoms just primarily on how the patient presents. And so this is going to be important because this is also going to give us an idea of how to manage these patients. Whether we're going to be able to start an antiviral for influenza or COVID-19, or even in the next few years, we're likely to see an RSV therapeutic hit the market. Secondly, a lot of these patients, depending on the pathogen that they might be infected with, may have risk for developing secondary bacterial infections. In terms of peace of mind, I know that especially during the pandemic, when patients would come in and you would test them for COVID if they were symptomatic, and they would test negative, and you say, well, you don't have COVID, and they'd go, great, I don't have COVID, but I'm still sick. What do I have? And so patients want to know what's going on, with them, what's causing the infections, what they need to do to, help mitigate those infections and keep loved ones safe. And then secondly, I'm going to throw this in here, multiplex tests, especially, again, coming out of the pandemic. We've seen a lot of new technology, both in our molecular test and our non-molecular test, which have allowed us to run multiplex assays very quickly. And so the idea that we have to test one test or one pathogen, wait for results, and then test another one, is really not the the way that we're managing patients these days. And so this really gives us an opportunity to get an idea what's causing an infection without delaying treatment. Next slide, please. In terms of the common testing platforms, the two testing platforms that you're going to see most commonly are the nucleic acid amplification tests, and those obviously encompass a lot of traditional PCR type tests, reverse transcriptase PCR, isothermal tests, and so forth. So we use nucleic acid amplification tests as a very generic term. Typically, these types of tests are associated with high sensitivities and specificities, and have the ability to detect low levels of circulating pathogens. Historically, these tests took a longer time to get test results. However, some of the real-time technology and some of the other tweaks to the technology, like CRISPR technology and so forth, allow us to get results fairly quickly. Fortunately, in these types of tests as well, using a cadre of different primers, we're able to test for a number of pathogens simultaneously pretty easily. On the downside, nucleic acid amplification tests historically are pretty expensive, have a risk for contamination. They do usually need some more expensive equipment to generate test results, and they don't differentiate between viable organisms and genetic fragments. So sometimes people complain that maybe these tests are too sensitive. With respect to immunoassays, these typically are like your antigen tests, things like the home COVID test, strep test that we used to see in doctors' offices and so forth. And these are really pretty simple to perform. And we can get test results from a lot of these assays within 5 to 10 minutes. The equipment that's used, some of these assays do have readers that are available to facilitate their use. Others are able to be read manually. And so therefore the cost of testing is significantly less in most cases with immunoassays. In terms of the downsides or the drawbacks, typically only get qualitative results, so you don't get viral loads and so forth. You might see variable sensitivity. And depending if you're doing a visual read versus an analyzer, if you're doing a visual read, again, it can be prone to error of reading because even a faint line is a positive line. So having good eyesight and good lighting is essential for the use of these tests. Next slide, please. What I want to bring up is the fact that I get asked all the time, okay, so what test is the best test? What's the ideal test? And I love this. I stumbled across this concept called situational relevance, and it allows me to answer all those questions by just saying it depends. There's no one size fits all. And if we look at high complexity PCR versus moderate PCR versus home or antigen weight tests, they all have a role in where they can be used. Now, in terms of looking at sensitivity and specificity, PCR-based tests might have the best performance. But in terms of throughput, a moderate or wave test might have an analyzer that you can only run one test every 15 minutes. And so that really greatly diminishes how many samples you can process. And the cost associated with the PCR, as I mentioned, was relatively high. In contrast, home use tests and CLIA-wave antigen tests, do have some limitations with respect to their performance, but those are getting better. The speed and the throughput are amazing. I can do bulk batch tests with some of these assays and run 20 tests at a time, 40 tests at a time. And the cost for some of these are incredibly low, ranging from $10 to $20 a test. So again, what I'm going to ask you is, if you ask me what test is best, I'm going to ask you, where are you testing? Why are you testing? And who are you testing? Because if you're in a resource limited area, or in a school or in an inner city, setting up a PCR might not be feasible, for a stand-up clinic. Where using a wave test or a home antigen test to support decision-making might be your best bet. Next slide, please. Along with this, have a lot of discussions about sensitivity and specificity of diagnostic tests. And what I would like to say is sensitivity and specificity are very great parameters when you're comparing one test to another test. However, in terms of giving you guidance in terms of how to interpret those test results for the use in a individual patient, they're pretty much meaningless. And we have to remember to keep an eye on the positive predictive value and the negative predictive value, because these values are going to fluctuate based on the pretest probability of a disease. So taking a good patient history, knowing if they've been exposed, knowing if there's disease in the area, all of those are going to increase your pretest probability, and therefore your positive predicted value, or the reliability of that positive test result, goes way up. Conversely, if you're running an influenza test in the middle of the summer where there's no known exposure, travel, and no disease circulation, if you get a positive test, that positive predictive value is going to be very, very low. So again, understanding positive and negative predicted value in terms of assisting you to make clinical decisions is going to be very important. Next slide, please. With respect to guidance for clinicians about when to test, as I mentioned, we've got a lot circulating these days. It's not just influenza. We've got COVID, influenza, and other viruses. Right now, the most common tests that we have to utilize in a variety of settings are going to be for influenza and COVID, and those are the two pathogens for which we do have treatments available. So currently, if an individual does require hospitalization, it is recommended that we do multiplex testing with PCR, or nucleic acid detection, for COVID and influenza. If multiplex assays are not available, then you would run each of those assays as to not to delay getting treatment results, or testing results, rather. If the patient does not require hospitalization, these recommendations I don't necessarily agree with, because I feel like they didn't take in multiplexing in the outpatient setting into account. And so if a patient does not require hospitalization, the CDC currently recommends testing for SARS by NAT first. Or if that's not available, then they say, okay, go ahead and use an antigen test. And then the recommendation is to sequentially test for influenza if that COVID test is negative, which again, I do not agree with the sequential testing. And even in this situation, they say only use the influenza test. It's going to change clinical management. And I'm going to make the argument, how would it not change your treatment decision knowing the results of an influenza test? And then they go on to recommend that a NAT be used for rapid influenza detection. However, again, I'm going to push back. If the antigen tests were good enough for COVID, if you didn't have a NAT around, these tests have gotten a lot better with influenza as well. So here again, I would also promote the use of a NAT. Next slide, please. Or excuse me, a antigen test, rather. In terms of making decisions to treat patients, first and foremost with influenza, the recommendations are to start treatment as quickly as possible in these patients, because we only have a 48-hour window from the onset of symptoms. So if the patient's being admitted to the hospital and they have signs and symptoms consistent with influenza, the recommendation is to test and then start empiric treatment. If the patient does not have signs or symptoms, well, then they probably don't have influenza. You don't test, you don't treat. If the patient does have signs and symptoms that you would think are consistent, like that ILI definition of influenza, and perhaps there's influenza circulating in the community, then the recommendation is, okay, will the test results influence the way you manage the patient? Would you start treatment? Would you not start treatment? Again, if you hit go, I'm going to hit forward on the slides. The question that they ask is, if influenza is clinically diagnosed, you can do that rather than testing. And I'm going to point out that I've seen a lot of data looking at the positive negative predictive value and sensitivity specificity of clinical judgment using ILI, even when influenza is present in the community. It's not good. I do not know why we would rely solely on clinical judgment if we do have good tests. So with this, if the patient is not being admitted to the hospital, if we think they have influenza, I am a firm advocate of going ahead and test, knowing I can get the test results back in 10 to 15 minutes. That is not going to delay my treatment recommendation, but it might potentially avoid exposing a patient to an antiviral medication needlessly. Next slide, please. With respect to treatment guidelines, we've got two classes of antivirals. We have the neuraminidase inhibitor And then we got the endonuclease inhibitor, baloxavir. And currently, antiviral treatment is recommended as soon as possible for individuals who are hospitalized, who has severe, complicated, or progressive illness, or is at high risk for influenza-related complications. For outpatients with, and again, they say suspected or confirmed, and I'm going to strongly rely on the confirmed or potentially ruled out uncomplicated influenza. We can use oseltamivir, zanamivir, peramivir, or oral baloxavir. With respect to the agents that we typically use, you're probably going to see most commonly oseltamivir and baloxavir, zanamivir, even though it theoretically might be a better neuraminidase inhibitor. Its use as an inhaled formulation is not incredibly palatable to a lot of patients, so therefore it is not used very much at all. In terms of one versus the other, I mean, we've all seen the meta-analyses in the Cochrane reports about oseltamivir and the neuraminidase inhibitors and questioning their utility. For better or for worse, it's kind of what we got right now, especially for severely ill patients. There has been one randomized controlled trial with baloxavir, which suggests that there might be greater efficacy in adolescents and adults with influenza B. So unfortunately, I think that we need more data before we lean on one agent versus another. But regardless of the way you go, it is the rapid treatment that's going to be important, getting the drug in the patient as soon as possible. Next slide, please. So along with that, I want to discuss a new model of care that my group started exploring back before the H1N1 pandemic, when I was working with Bob Cadillac from the Bush administration. And we wanted to find ways to improve the access of patients to healthcare to get them tested and treated for influenza. And that's where these test and treat models have started to evolve. And over the years, we've evaluated these type of methods where individuals would go to a pharmacy and under a protocol, evaluate patients, test them when appropriate, and provide treatment very quickly to these individuals. And what we found is in a lot of cases when patients present to a pharmacy, we can test, fill a prescription when necessary, and get these individuals home within 30 minutes of their presentations, where we found a much greater delay when we were comparing to more traditional means of care, going to an urgent care physician's offices and so forth. In terms of how widespread this is becoming, there's over 26 states currently that allow for some level of pharmacy-based population-level test and treat programs, and a lot of legislation is pending prior to the ending of the PrEP Act in October 2024. So it's likely that we're going to see many more of these programs pop up. Next slide, please. Our group took a look at all the data that were out there, especially looking at influenza related models. This is not something that we've just seen in the United States. These models are in Canada, the United Kingdom, Australia, New Zealand, and so forth worldwide. And consistently, kind of our take home, and I think that's the next slide. Oh, first of all, before I go through the take home on that, let me go through the kind of flow of what one of these regimens would look like. So go ahead and go to the next slide, please. In terms of what these models tend to look like is when the patient presents to a pharmacy, they will typically self-present, indicating that they, are feeling ill. Pharmacy staff will complete a intake, including a medication history, medical history, and a vaccine history. They'll also conduct a physical examination to determine the clinical stability and any signs or symptoms the patient might have. If no testing is indicated, individuals go away from the pharmacy with recommendations for symptom management. If testing is recommended, then based off of the results of the treatment or the test result, patients may again receive symptom management recommendations or be provided with an antiviral in the pharmacy. If you could hit, then go forward once. Of key, part of the assessment is to identify clinical stability and risk for progression to severe disease. If these individuals are identified by the pharmacy staff, what best practices have been recommended is that when indicated, antiviral medication be started immediately, and then these individuals be discharged from the pharmacy to their primary care provider or an appropriate location of care. The other item that is recommended for best practices in these models is a follow-up. Regardless if the patient is diagnosed with influenza or discharged with symptom management, pharmacists and pharmacy staff are suggested to call patients within 24 to 48 hours after their initial presentation to the pharmacy to determine how they're doing and whether additional follow-up care is needed. Next slide, please. In terms of some of the big takeaways from these models that we've seen, and I've already mentioned, it greatly reduces the time needed to receive treatment. And one of the key statistics that we always, quote, in the pharmacy world is about 50% of patients live within 1 mile of a pharmacy, and over 97% of individuals live within 5 miles of a pharmacy. So the accessibility, the expanded hours, and so forth are there. So patients are able to find a pharmacy, whether it's their hometown or they're on vacation or visiting relatives or going to college. So that really improves the access to care and shortens the treatment. Another thing that we find is even though everybody theoretically has insurance in the United States, 30 to 40% of individuals still do not identify a primary care provider. These tend to be younger individuals, maybe even up to and including 45 years of age, where they have not had a lot of chronic medical conditions or medical conditions that have prompted them to establish a medical home. So these individuals, when they get sick, tend to go to urgent cares or emergency departments. And in the studies that we conducted, we found that about 30 to 40% of the individuals that utilized the service did not have a primary care provider. Additionally, in terms of the access to care, about 30% of individuals access these services outside of normal office hours, evenings, weekends, holidays, and so forth. One key finding was that for influenza especially, we only had about an 11% positivity rate with our influenza test when we did this initial study. And so we administered oseltamivir to about 11% of the individuals. However, our patient satisfaction rates were greater than 90%. And so this kind of dispels the idea that patients are only going to be satisfied with their care if they receive a product. Really what they want is they want to be heard, they want their symptoms validated, and they want a plan for what to do. And also important to find out from all these studies that there have not been any compromise in patient outcomes or safety. Next slide, please. The one thing that we always do related to these visits in the pharmacy, kind of building off Dr. Hewitt's presentation, is promote immunizations. Whether or not the patient has influenza, does not have influenza, that is not an exclusion if they're ill not to receive a immunization. So we will always offer immunizations to the patients at each of the visits. And looking at last year's data from the CDC, pharmacies resulted or provided roughly 42 million influenza vaccines to adults across the country, whereas about 32 million influenza immunizations were provided in physicians' offices. And so just saying that the pharmacists, in collaboration with other sites, provide an incredibly valuable site for people to get their immunizations. And I'm going to end by saying, remember, I think influenza is coming early this year. So please encourage your family members, your loved ones, your patients, your colleagues to get their influenza vaccines early this year and not wait till December, because I think by December it might be too late. And we might already be in the midst of our influenza season. Thank you. And so I'll turn it back over to Dr. Lagiovia.
Thank you, Dr. Klesper. That was excellent. And if you could please unmute yourself, and Dr. Hewlett, if you could please turn your camera back on and unmute so we can start the question and answer portion of the webinar. So we have a number of questions in the chat, and I'll start with you, Dr. Hewlett. One question was, in addition to optimizing the compliance and vaccination, for COVID and flu, is there any evidence that combined vaccination increases immunogenic responses?
Well, that's a great question. We know that the two vaccinations can be given together. We know that the two vaccinations actually will be immunogenic if they are given together. However, one principle that we also know is that most of the time when we give two vaccinations together, the immunogenicity of both of the vaccines is actually decreased slightly. With that said, we still recommend that when people come in for the vaccination for influenza or COVID vaccination, if both of the products are available, we urge people to take both of the products on the same day. But that's my understanding of it.
And then also along these lines, when we talked about timing, Dr. Klesper, also, if you wanted to chime in, sometimes we see these ads to start getting influenza vaccine as early as July and August. And the perennial question is, when is the best time to get it? And you've mentioned that you think that December is too late, but is there a sweet spot at this time of year?
Well, first of all, I'll clarify. It's not too late. If you haven't got your vaccine, always get your vaccine, as long as it's there. Typically, the new seasonal influenza vaccine comes out, in September. And people always want to wait until they think they're going to run out of the protection. But again, if you don't get it, you can't determine when we're going to have influenza season. And so if you're counting on it being in January, look at the past few seasons, that we've had. They've been in, early January, December. So if you wait, you might miss it. Now, even if you get it, still get your immunization because you still be protected against 3 other strains potentially. So sweet spot, get it before people start going back to school, get it before you start traveling, get it before the weather turns. And so I'm a big proponent of, if it's there, let's start getting it, let's start using it.
If I could add or piggyback on to those excellent comments, those individuals who are immunocompromised should actually place themselves at the front of the line because they are the ones who are at the greatest risk, and they certainly should try to protect themselves as soon as possible. So as Dr. Klesper was saying, as soon as the vaccines become available, we typically encourage our immunocompromised individuals and those individuals who were included on that list of those at high risk for them to get the vaccine as soon as they can.
And in terms of money where my mouth is, I took my whole family last weekend and we all got our influenza shots. So.
And I'm getting mine this afternoon at the hospital as soon as this is over.
Excellent. Now, something that was a concern with COVID vaccines was side effects such as myocarditis. And a question in the chat was regarding if there was any comments from the presenters about either influenza infection and myocarditis or flu vaccine and myocarditis.
Well, we know that myocarditis, the most common cause of myocarditis, at least among younger individuals in the United States, are viruses. And we know that both the influenza viruses, A and B, can cause myocarditis, as well as SARS-CoV-2 or COVID. Fortunately, these are rare occurrences. One of the things which everyone should keep in mind is that these diseases can be associated themselves with myocarditis, and the likelihood of the disease causing the myocarditis is likely higher than the vaccine causing the myocarditis, at least according to the numbers that I have seen. It is my understanding that myocarditis following the influenza vaccine is very rare. And in most cases, these situations are usually reversible. With the COVID vaccines, I think that everyone is familiar with some of the data related to the mRNA vaccines, that there were cases of myocarditis occurring, particularly in young adolescent males. And fortunately, in nearly all of those cases, it was self-limited, and the symptoms abated with rest for a couple of days in these young individuals. And in most of the cases, if they had to be hospitalized, it was not for a prolonged period of time. So I think that the vaccinations are extremely safe when you compare that with what actually happens if you're not vaccinated and you actually contract the disease.
Right, right. Now, shifting gears to antivirals. One question involved, it said the ASHP published their policy statement supporting over-the-counter access to multiple flu antivirals. Is there any thoughts or comments on this, and how might this impact access?
So I'll take a stab at this. I'm not a huge proponent of over-the-counter type of access to stuff like this because people may be utilizing these medications without really having a good diagnosis. Now, if there's things put in place with respect to home testing and telemedicine follow-up, or test and treat in pharmacies, I believe in appropriate access. But we do know that with these medications, especially looking at data from Japan, where these medications are widely used, much more than historically they have in the United States. There are populations, especially younger individuals, where there are some significant side effects. And when you take away some of the ability to counsel patients on who's appropriate for use of these medications, then I start to think that you have some risk associated with them. And people, even though it says on the box, do not administer to people less than 12 years of age. First of all, my eyes are so bad, I can't even read that. And we all know that people are horrible at following instructions. So I'm not a fan of strictly over the counter. Now, there might be something in terms of, they've discussed kind of behind the counter kind of classifications where you have to have a consultation, to get the medication. But again, I still see some issues related to that as well. So not a huge fan from my perspective for that.
And again, if I can piggyback on to Dr. Klesper's remarks, as an infectious disease physician, I am certainly very concerned about the emergence of resistance. And certainly it's a big problem with our antibiotics, and it also is potentially a problem if we overuse our antivirals. And I think that's another thing that we have to consider. If we start having overuse of these products, then they may become less effective, and it may take away one of the things that we have to effectively treat our patients who really are in serious need.
I completely agree. We have so few options as it is. And while the armamentarium may be growing past its prologue, so judicious use of antivirals is so important.
Well, and to that point, I mean, look back at, was it 2008 with oseltamivir? 98% of all the H1N1 isolates were resistant to oseltamivir before the pandemic. And we were concerned that maybe we'd run into that situation. Fortunately, they kind of got outcompeted or whatnot, but that is definitely a concern, even though we haven't necessarily seen a lot of that historically with influenza.
So given that now there are several options for treatment of influenza, do you have any comments or pearls about choice of agent, whether baloxavir or oseltamivir, any patient-specific factors you'd want to highlight when you're coming up with choices?
So from my perspective, first of all, it's going to be important to look at the approved, indications. And oseltamivir obviously is indicated for a greater array of patients, younger age, more severely ill. So for baloxavir, it just really does not have, all those clinical indications. So you might be a little hand-tied if you're doing letter of the law kind of prescribing. In terms of, familiarity, got a lot of familiarity with oseltamivir still because of the pandemic. I don't have as much familiarity with baloxavir. I like what I see. I like where it's going. I like the compliance aspect. But at this point in time, I'm going to look at each individual patient, assess their risk and their likelihood of compliance, and make a decision based off of that.
Pivoting over to testing, a question had been put in the chat of, is there any comment on using the antigen test outside of the influenza season in light of their potential low predictive value?
Yeah, don't do it.
I think
That's really, unless you have, been traveling to the Southern Hemisphere, unless you have a known exposure, you don't do it. The likelihood that you have influenza is incredibly low. At that point in time, your probability of having maybe a different virus or COVID are much higher. And, that's one of the reasons I do like having a multiplex test. I can test for, many things simultaneously to give me a better idea. But that's where talking to the patient, understanding things, and, again, using them appropriately. A test is a tool. It's not a solution.
Yeah, I like your the philosophy of situational relevance. It applies to so many aspects of infectious diseases, and we have great power to identify pathogens, but it takes a lot of responsibility of knowing when to harness that.
Yes.
There was some discussion about the follow-up after a visit into the influenza disease management program. Could you discuss that a little bit more in terms of what is the method of follow-up and what's the best timing?
Well, so what we recommend is that there be some follow-up, and we unfortunately know that in traditional medicine, you don't have a lot of follow-up. Patients go home, they're gone. We assume if they get better, they get better. If they get worse, they come back. But what we wanted to try to do is, knowing that a lot of these individuals may not have a primary care provider, to at least check in on them 24 to 48 hours later to see if the disease has been progressing, see if their symptoms are getting better. And then if there is a need to schedule another telephone visit, we would do that. So most of these are going to be telephone visits. In terms of the cost that it takes to do that, it's truly maybe a 30-second call, talking with the patients. And the patients are very, very happy that somebody took the time to call in with them and just to see how they're doing. And, from our perspective, this is one of the greatest values of that is, yes, it's a safety net, and two, it's the satisfaction. And then you feel good. Well, I didn't have to give an antibiotic or something or an antiviral because I know I'm going to, call them back. And the patients understand that and appreciate that as well. So typically 24 to 48 hours for the first follow-up by a telephone call, unless they come back earlier.
And if I can add one other thing to this too, and Dr. Klepser highlighted this, that is, some patients will have a biphasic disease. That is, they will have the illness due to the influenza, and they will then start to feel better. And then a day or two later, they start to cough again, and they're bringing up yellow or green sputum. And in those situations, we have to be aware of the fact that these patients are at a higher risk for developing a secondary bacterial infection, either bronchitis or pneumonitis. And those patients actually do require antibiotics. And that's when we should get involved with seeing them. And this is why these follow-up assessments are so important.
So I see that we are just about out of time. And so if there are any questions we missed, we will do our best to answer you via email. Thank you so much again, Drs. Hewlett and Klepser. You had excellent presentations, and it's the perfect timing this year. I'll pass it back to Diane to close us out.
Great. Thank you so much. The IDSA Foundation extends its appreciation to Drs. Klepser, Hewlett, and Lagiovila. Thank you to our audience for your attendance and participation in the Q&A session. If you wish to revisit this webinar or share it with others, a recorded session will be made available to you via email and on our website and YouTube channel. We hope you'll join us after ID Week for our upcoming webinars that will cover topics such as hepatitis C updates on the current respiratory season and vaccines, recurrent C. diff, and AMR. We post about our past and upcoming webinars on our social media channels, so please take a moment to connect with us there. If you're interested in becoming a member of the Infectious Diseases Society of America, please don't hesitate to reach out to us or visit the IDSA website. It's hard to believe ID Week is only 2 weeks away, but there's still time to register. And finally, we kindly ask you to consider furthering your support of the IDSA Foundation with a personal donation. Your gift plays a pivotal role in advancing our mission of ID workforce development and making a tangible impact in the field. Thank you again, and have a wonderful rest of your day.